Welcome to the Sandwich Crunch, where we navigate the multi-generational trends and issues impacting boomers and seniors at home, in the workplace, and our community. And I'd like to introduce you to Debbie Shelly, my guest tonight, and we will be talking about HICAP, which is the Health Insurance Counseling and Advocacy Program.
Correct.
Out of Area 12, and you represent all 5 of our counties that we work with: Mariposa, Tuolumne, Calaveras, and Amador.
And Alpine.
And Alpine.
Correct.
So it's very nice to have you here.
Thank you.
I thought to get things started, because I really enjoyed you sharing with me your story about how you got involved with HICAP, because you've got quite an extensive background, and you're also from Ireland, and all
my heritage, yes,
your heritage,
definitely.
quite a few things. So I thought we could start off with that, Debbie.
I started off at Area 12 11 years ago, and I started off as part-time HICAP, part-time information assistance, also known as INA. And Larry Botiford was the program manager at the time, and unbeknownst to me, he was grooming me to take over for his retirement. So that's how I became the HICAP program manager, went from part-time to full-time, and I absolutely love it. It is it's a puzzle, and it's a challenge every day, and I go to more school now than I ever did in school, and I love it. It's great to be able to help people.
Well, I'm glad you are doing it, because I had actually done some research on taking courses on Medicare A and B, C and D, and understanding that. And after reviewing a 1,000-hour course, I thought, you know, I'm really glad we have Debbie. Because that is a
1,000 hours.
That
doesn't sound like enough.
And after talking with you before, it is amazing. Mm-hmm. It is a puzzle. It is dynamic. There's constantly changes, and there's constantly new things that are happening in the insurance industry that affect Medicare, and not only with the new Obamacare and all these other insurance programs going on, but also we're dealing with different issues that are different for each person.
Correct. Every person's situation is so individual to their needs and where they're coming from. To be able to meet their needs, yes, every single one of them is totally different. Totally different.
And one of the things we were just talking about before we went on air is that our county and Tuolumne County are the fastest growing retirement counties in the nation per capita.
Per capita.
With the exception of one county in Florida.
Correct.
And Utah is the lowest, actually.
Yep. I didn't know about Utah, but I did know that we were, and Florida were high. So, and we're growing consistently. And boomers, 10,000 a day, are turning 65, going into Medicare.
Exactly. I know I'm going to be 53 and 62, so I got to wait. I'm 53 in September, and I'm thinking, I got a little ways to go. So there are a lot of people turning 10,000, or 65-year-olds turning 10,000 people turning 65 every day.
Every day.
A lot of people turning that. So we do have a lot of growth in the industry, turning seniors, and that 65 age is a very key number.
Very key.
And I thought we could start off with that, because that is a large misconception with many individuals out there. They misinterpret Social Security with Medicare.
Correct.
And I thought maybe you could address that.
A lot of people, and we've had quite a few people come into the office, oh, I need to sign up for my Medicare. And I'm like, okay, how old are you? 67, 68. I'm like, oh. I said, were you working? No. Was your husband working? No. Well, why did you wait? Why are you waiting? Well, we thought we could get more if we waited, meaning more money. But that's Social Security, not Medicare. Medicare starts at age 65. You're eligible for Medicare at 65. If you wait, you either need to be working, or your spouse needs to be working and receiving employer group coverage to be able to postpone Medicare. Otherwise, you've incurred a penalty. So this money this couple saved actually cost them 60% more, because it's 10% per year for every year you're not in it and you're eligible. And that's 30% for each one of them.
And that's a lot of money.
Yep.
So a clarification, everyone, Social Security and Medicare are not meant to be deciphered in the same way. They are different programs, and you must address Medicare when you're 65. Social Security is an entirely different ballgame. Yep. So when we get
unless they're disabled.
Unless you're disabled. So then there are some exceptions that we can talk about. But on the general rule, 65
is your
for
number.
Medicare.
Yes.
Yep. So
they're not changing that. The Social Security changes based on when you were born.
Yes, and it changes. That has a whole other
and I'm
ball
not touching
game
that
of
ball.
numbers. I read about that, and that just turns my stomach. I think the I think a lot of these legislators are sitting back there at midnight drinking tequila and making these laws so challenging for us that they try and get us all mixed up so that we sign up at the wrong time.
Or don't sign up.
Or don't sign up at all.
Out of fear, yes.
Yes. Well, let's start off with Medicare and really talk about Medicare A and B, because there are a lot of misconceptions about Medicare, what it covers, what it does not cover. And you have Medicare A and B, and then you also have the combined program.
Which is, would you mean Medicare C or Medicare Advantage, known as Medicare Advantage. So if you start off with Medicare Part A, Medicare Part A is usually free based on your work quarter. So if you have 40 quarters worked, your Part A will be free. If you haven't worked the 40 quarters, you will have a payment. And I don't know the numbers, so just leave it at that. Your Part A is your hospital, your psychiatric hospital, your hospice, yes, and home health, and home health. So those are your Part A. Your Part B is you have a premium that'll come out of your Social Security if you're receiving your Social Security. If you're not, then they will bill you. For 2014, it's $104.90, $104.90.
Per month or per year?
Per month. That is a per month. If you're not on your Social Security but still receiving your Medicare, you could have it billed monthly or quarterly.
Okay.
It's up to Social Security and you to decide that, not anybody else. The Part B is your doctors, diagnostic, durable medical equipment, your outpatient psychiatric care, and ambulance. Those would be your Part B.
Now, would Part B also inclusive of, say, like when my mom broke her hip?
Rehab.
Rehab. So
rehab would be on Part A.
Part A. So
yes.
Speech therapy, rehab, and all those. So speech therapy, rehab, and what other types?
Occupational, physical, PT, and physical therapy, occupational, and I'm forgetting one, but there's 4.
So we've got speech therapy, we have
physical therapy, occupational therapy, and one more.
Yeah, I'd like to remember that one too. Gosh, I'm not a specialist in this, but what the heck, you know,
it's rehab. It's under the caption of rehab.
That's what high temperatures will do to you when you're outside. I got to tell you, it's really tough out there. So that is a very, very interesting area because I know for my mom, it was all covered.
Yes.
And with her, I mean, that also included a short-term visit within a facility, a rehab facility, and then she came home and had additional rehab. But it was for a short-term period of time.
But the rehab is only covered if you've had 3 midnights in a hospital.
So explain that, because a lot of people, I bet, are really confused right now.
They're very confused. People get very confused, and it kind of leads into another little sidebar on that. But in order for Medicare to pay for rehabilitative care in a facility, a beneficiary must have 3 nights stay admitted into a hospital. Admitted, not under observation, but admitted into the hospital in order for Medicare to pay for the first 20 days of rehab. If they don't have the 3 nights admitted, the client can still go to a rehab facility, but Medicare's not going to pay a dime.
So it'll have to come out of that client's pocket or another insurance program they may
Supplementary will not cover it either, because if Medicare says yes, the supplementary says yes. Medicare says no.
So this is a really wise decision for anyone getting ready to go into Medicare, or every year there are annual renewals on Medicare. To sit down with an individual such as yourself, when you have everything there and you can lay out the picture and explain, okay, this is what is happening, this is what you're going to qualify for, these are your needs, because there are going to be various needs for people.
Correct.
Because of different chronic illnesses.
Correct.
And different
personalities.
I would imagine that plays a big role in it too.
It does. I mean, you could have Mama Joe who breaks a leg and goes to rehab. She's been in the hospital. Let's say break a hip, because usually that is 3 or 4 days. Goes to rehab. She doesn't want to do the rehab, and she tells them, I'm not going to do the rehab. Well, she goes from rehab to custodial care in that very sentence, and Medicare no longer pays for her stay. She needs to be receiving, she has to receive the rehab for Medicare to pay for it.
So you have to follow the rules. You can't be a rule breaker.
You can try. You can definitely try.
But if you want it covered, you better be meeting with Debbie. And
you got to have your 3-night stay in the hospital and definitely do your rehab. definitely.
Okay, wow, that is a lot. So when we're talking then about B, we're talking about doctors, diagnosis, diagnostics. So diagnostics would be
your labs, your X-rays, MRIs, tests, your lab tests.
Now, what lab tests are not covered?
Well, I can't say what is and is not covered because Medicare is totally based on medical necessity.
Okay.
So I don't need an MRI because I have a broken nose, I guess. I don't know. I'm not a doctor, but medical necessity becomes the primary. So whether a test is necessary would be if it's medically necessary.
And that's determined by the doctor's diagnosis?
By the doctors and it could be the hospitalist. If you're in ER, that would be the determining factor. Medical necessity is the bottom line when it comes to Medicare.
Okay, so if you are going to a doctor and say you have cancer and you were already on Medicare, so you've already accepted you into the program and you've gotten diagnosed with cancer, and say they have a new treatment, something really new that's out there, does Medicare engage in progressive treatments?
If they have contracted with Medicare and if it has been approved by the FDA and it has been put into the Medicare codes, then they would. But there are treatments that Medicare does not pay for, that are, or the facility doesn't take Medicare. I mean, there are cancer centers that do not take Medicare. They don't take Medicare, and they can get more money by not. So sometimes it's not necessarily Medicare, sometimes it's the facility that doesn't want to deal with it.
Well, and I imagine a lot of doctors as well who are going private and saying, I don't want to have anything to do with the HMOs, the PPOs, or any of those things. I want to have my own practice, not have the umbrella of any kind of an insurance organization, and I'll negotiate with my clients.
Those are ACOs. A lot of ACOs are coming out of accountable care organizations, but they still deal with insurances. You have your concierge doctors they pay like a membership, but they still deal with the insurances. So I don't know. I haven't seen up here where the doctors are not accepting Medicare. They can choose not to be a Medicare assignment doctor, which means they can charge an extra 15%. But I would say 98% of the doctors and facilities up here do accept Medicare. Original Medicare, I will specify original Medicare. When you get into HMOs and PPOs, that's a whole different ballgame. And those become a contract between the insurance company and the doctor, not Medicare and the doctor.
Okay. Gosh, so this just gets more complicated. I don't know about you guys out there, but I know insurance is complicated, and
you mix Medicare and insurance together, and you do have a maze.
And then you have the national insurance program, and you've got a bigger maze. It's a big puzzle.
We're not part of the national exchange program because we have covered California. We're a state exchange, and I'm going to give my little spiel now because you opened the box. But anybody who has Medicare does not need a covered California policy. They should not purchase one. They should not even be calling on one. If they had one prior to turning Medicare, they should cancel it when they get on Medicare because they do not work together.
Okay, so if they're already covered under that, they can actually transfer over without any penalties.
Drop it.
But if they're 67, they can transfer over without penalties.
Oh no, they'll have penalties.
Oh, because
your Medicare penalty starts when you're eligible, not because you had credible coverage. If your credible coverage has to be linked to a employer group health coverage plan. That's the only way you can postpone your Medicare with no penalties, or if you're not living in the country.
As I said, this is extremely complicated, and as I will reiterate, this is the most important area of your life as you are turning 65, is to sit down with a professional who knows insurance, who knows Medicare, because it's also not the same as Medi-Cal.
Oh, Lord, no. Two different ball games completely. Medicare is the federal program. Medi-Cal, known as Medicaid in every other state of the union except for California, is your state-run program. It still gets federal monies, but it's based on income. Federal program, Medicare, is your age entitlement program.
Oh, this just gets so complicated. But
it's fun.
It's fun. I know. That's why it's a big puzzle.
It is a big jigsaw puzzle. That is exactly.
So we've talked about you having different clients. I mean, that every person is different. They have different experiences, and they have different issues that are compounding what they may or may not need. So would you have some examples to share that might help the audience understand a little bit more? Because we do have a large retirement group of individuals, and we do have a lower economic group of individuals, but we also have a very high degree of chronic illness. Actually, I'm taking a healthcare training over at Mark Twain right now, and I sat in a class, and it's on chronic illness, and of the class, 70% were diagnosed with diabetes.
Yeah, that's one of the highest growing.
Yes.
Goes along with their obesity rate.
Yes.
So, yeah. Okay. In regards to every single person that's turning 65, their situation could be different in regards to many different things. Their income could be one, if they are still working and have employer group health coverage, or not, and their spouse is still working and has employer group health coverage. We've even had spouses that were separated, not legally, living in separate households, but technically they're still married. That's a whole different ball game. You know, I mean, what Medicare feels that they are. If they're still considered married, their incomes are still together, even though they're not living together. It's a whole different ballgame. So, which could knock them out of any of the subsidies that might be available to one of them that is of the lower income. But they're, see what I'm saying? Their income taxes as a couple throw them out.
That's interesting. So that's another area that has to be looked at. Now, a lot of this you have to deal with not only a Medicare expert, but also your accountant.
If there's an issue, we definitely ask them to talk to, if they have an accountant. I mean, if you're talking of a lower income, they don't have an accountant. So they will bring in their Social Security statements, their bank statements, or nothing, and tell us. I mean, they could come in with everything, or they could come in with nothing, and they'll say, okay, I need help. But a lot of times, half of them don't even know what kind of help they need, because they've been talking to their friends and they've been talking to their neighbors, and everybody has the greatest intentions and the best information based on their experience.
Okay, very, very much of a qualifier is their experience.
Mama Joe could have a totally different situation. She might live in a beautiful house and she might come off fine, but she might be living on $600 a month and the neighbor next door is living on $3,000 a month. Those don't even compare, but they can be next door neighbors.
And no one would even know it.
Exactly. So Mama Joe comes in, she starts talking, and we will probe for questions to find out what the situation is and what actually she might be entitled to and what she might be eligible for, and then we will present it to her. If she comes in for just one thing alone, we will still, in the conversation, other things will come up, and we will say, okay, do you know that you might be eligible for this? Or, no, I didn't know, you know, and
so what type of programs could they be eligible for?
Under Medicare A and B and D, there are many programs. There's what they're called the Medicare Savings Programs. There is the QI program, which helps pay for their Part B premium and their co-pays. So it's like having a supplement without paying anything. There is the SLIMB, Select or Limited Medicare Beneficiaries. It pays their Part B premium but doesn't pay the 20%. Then there is the QI, and it's a higher income, and it pays their Part B premium, and then they believe they have a $20 co-pay when they go to the doctors. Okay. Those are the three QI, or the Medicare Savings Programs. Then there's also the Limited Income Subsidy, which is for Medicare Part D, the drug program. And that a lot more people are eligible for because the income is much higher. The incomes for the Medicare Savings Programs are much higher than Medi-Cal. The assets allowable are much higher. And then the best part is that the Medicare Savings Programs are not asset retrieval. There's
like Medi-Cal is.
Yes.
Yes, they come back and they can retrieve your assets after something has happened.
Medicare Savings Programs, as of 3 years ago, are no longer asset required.
Well, that's a good thing.
Yes.
Actually, a really good thing. Well, I have a question because I had read that under the program you get an annual physical type of thing. They don't actually technically call it a physical.
It's not a
physical. It's a wellness.
It's a wellness check.
So it's not.
It's a baseline.
It's a baseline. So you get it annually, but it's not a real physical. Not like the doctor taking that little thing and checking your need. Is it?
Oh, that's part of the physical.
Oh, it is?
Yeah.
Oh, okay.
When you go to the wellness check, it's your eyes, your weight. They'll check if they think that you might have the stomach where the vein blows up. I can't remember what that's called right now. They can do that. They can do an electrocardiogram in your wellness visit if it's needed.
Okay.
If it's needed. If your wellness check goes great, you're done. But if they find something, then they can send you for diagnostics. That would be covered under Medicare Part B with your deductibles and copays due.
Okay, so now that's a clarification for me because I had read wellness, and all I had was this image of going to the doctor and just doing a little checklist of, oh yeah, I'm doing fine, doing this, and looking at my tongue and looking at my eyes and ears, but not doing an actual full physical. So
it's not a full physical. It's not a full physical, and when they first came out with it, they did call it a physical. Now it's a wellness, a welcome to Medicare checkup, and then it's a wellness visit. And it's kind of
annual one.
Annual wellness visit, and that's whatever the date of your first welcome visit was, then that becomes your anniversary, and you'll get notices, or if you have their mymedicare.gov, they'll send you an email. Hey, you're due for your wellness visit. It's more of a baseline, and the idea behind it is preventative care, because a lot of things that, I always use Mama Joe as a name, might not have noticed the doctor would with that baseline. You know, her weight fluctuates one way or the other. Her blood pressure is gone, skyrocket. She no longer can see the numbers on the board. Those are all prelims to something else that the doctor can investigate. But they wouldn't go in for those wellness checks if they had to pay for them.
Now, in a wellness check, would they also do a blood test just to see if there's any kind of blood sugar?
No, they wouldn't do blood tests are not included in the wellness check. But if there was clues to something, or, I don't know if that's the right word their doctor would use, but he could definitely send them. And, I think we need to check this out and send them at that point.
So this is a really excellent opportunity for a patient to be very, very frank with their doctor and trust that their doctor is there by their side to help them. Because I know that so many patients are afraid to say what really is happening, and they're actually doing themselves a disservice because they can actually prevent something from happening or progressing.
It can be so small now that, just, giving up something could fix the issue. They could have potassium overload or whatever, and just the doctor can tell them how to fix it. That simply, but if it goes on, who knows? It becomes a chronic illness.
Right.
Diabetes, anything like that can all be, well, I shouldn't say it all, but if they catch it early enough, they can, We've had a client that was told that she was pre-diabetes. He said, you do this, this, and this, and lose 20 pounds or whatever it was. She did it. She's no longer pre-diabetes, but he caught it at a wellness check.
And that's a really healthy way of working with a doctor.
Yes. It's preventive. It's a pre, it's getting it before it becomes a problem. And the whole idea behind the Medicare preventative services is that, your mammogram, your PSA tests, the obesity screening, depression screening, smoking cessation, those are all preventative.
Okay.
There are some that when they're in like colonoscopy, I'll go colonoscopy because that's usually the one that comes up in the office.
I've had one.
If somebody
not fun. No. I've had an endoscopy too.
No, I've had both too. When you have a colonoscopy, you're usually out, and so they're doing a preventative service. But if during that preventative service they find a polyp, it's no longer preventative; it becomes diagnostic.
Okay.
So if when you go in for this colonoscopy, you have no deductible and you have no copay because it's under the preventative services. If you don't have a supplement and they find a polyp, you're going to have your copay and your deductible due when you walk out the doctor's office because it went from preventative to diagnostic.
Well, this is an extremely fascinating arena in insurance, and it's extremely complex to anyone. I don't care how educated you are. I think this is one of the most difficult arenas to get into. And with all the different insurance programs that are out there, the complications, and then alone taking on the individuality of it, you are dealing with an entirely, it's its own ball game.
Yes.
Well, on that note, I want to thank you, Debbie. We are going to join again, and we're going to really get a little bit more into talking about Medicare C and D and some of the misconceptions about long-term care, and talking about more that people really need to be aware of about Medicare and understanding the value of connecting. So thank you, Debbie.
Thank you very much.
And again, thank you all for joining us, and we look forward to having you join us again at the Sandwich Crunch, where we navigate the trends and the issues for seniors, boomers, in the home, workplace, and the community.